In Essential Task 913, we are going to describe the treatment techniques used in biological therapy. This essential task is going to conclude our unit on clinical psychology, and it's going to approach treatment a little bit differently than some of the others. No longer will we be talking about psychotherapy, therapy techniques that are based on theories of psychology, like we did with insight, behavioral, and cognitive. Instead, we're going to approach things from a more biomedical or biological perspective. We're going to be talking about things like drug use and then even types of brain stimulations. I think today is definitely a horizontal concept map, as you hopefully just noticed, but I will allow you now to pause the video before proceeding into the concept map. We will first start on the left and talk about the drug therapies that are available for the treatment of the disorders in this unit. Before getting into the actual disorders and the drugs themselves, we need to talk about some careers and some fields within psychology so that in case you see them on the AP exam, you're clear what is being talked about. The first is the term psychopharmacology, which is essentially a profession or a field that you could go into where you would study the effects of drugs on the mind and behavior, meaning you would essentially trial how new drugs affect behavior and potentially see whether or not those drugs are appropriate treatment methods for some of the disorders in question. If you have more of an interest of working with patients as opposed to in the sort of testing field like psychopharmacology, there are two career paths that you could go into, and they have sort of different qualifications. The first is being a clinical psychologist. Clinical psychologists are trained to assess psychological stresses like disorders, but it does not require a medical background. You don't have to have a doctorate to be a clinical psychologist, and therefore you cannot prescribe medications. So you might work within schools, you might work within social settings, you might work within the community, but you do not have the medical background. You did not go to med school, and therefore you do not have the qualifications to actually prescribe medications, but you absolutely can work with psychological stressors in a variety of different environments, which in some cases, of course, would warrant working with patients with some of the disorders that we've talked about this year. On the other side, if you're willing to go to medical school and you're willing to invest the time and resources into doing so, you could become a psychiatrist or practice psychiatry, which are in fact medical doctors who are in fact trained to treat and diagnose the disorders that we've been talking about. And of course, as I mentioned a moment ago, they can in fact prescribe medications. Some therapists are psychiatrists as well. They have a background in medicine and can actually prescribe. If we watched more of The Sopranos, which we watched a little bit of a few essential tasks ago, Dr. Melfi, in the context of The Sopranos, did have a medical background. So she treated Tony, the main character from that show, in that therapeutic style, but also was able to prescribe medications for him to use outside of the environment. As a mnemonic, when I look at the word psychiatry, this one might sound a little bit weird, but I say it out loud, and it kind of sounds like the phrase "sky high as a tree," particularly if you say it fast enough, "sky high as a tree." When I hear the word high, I can sometimes think about drug use, and that's how I connect psychiatry to specifically the career within this topic that's allowed to prescribe medications and drugs. Proceeding onward into the actual topics of drugs itself, there are different types of drugs that you could use that have two different effects, and that will be important when we actually talk about the four categorizations of drugs that we need to know for the AP exam. The first thing that we have to talk about, though, are how drugs affect the chemicals in your body. There are really two different types of drugs: agnostic drugs and antagonist drugs. Agnostic drugs isolate and identify neurotransmitters in your body and amplify their effects. So when you take these drugs, they can, in some cases, inhibit reuptake, meaning they lock neurotransmitters in the synapse longer than is natural. Some of them are chemically similar and mimic the neurotransmitter, so your brain perceives them as if it is actually the neurotransmitter. And in either capacity, the presence of an agnostic drug is going to increase the effects of a neurotransmitter in your body, whether that's dopamine or acetylcholine or GABA or some of the others. As a mnemonic, I look at the AGO at the beginning and I think of AGO, simply a term referencing let's go, let's continue this activation, let's amplify this neurotransmitter. However, there are also drugs that will do the opposite: identify, isolate, and reduce the effects of specific neurotransmitters in your body. To give you a preview of what that might look like, we talked when we first discussed schizophrenia that one of the leading theories that's backed up by quite a lot of science is that the effects and symptoms of schizophrenia are a byproduct of overactive dopamine in the brain. So if we use drugs like antipsychotics that reduce dopamine activity, we might actually see a reduction in symptoms, which we actually will typically see with our patients. So when we use a drug that decreases the effects of a neurotransmitter like dopamine, we're using an antagonist drug. When I look at the beginning of the word antagonist, it sort of reminds me of the phrase ain't going. I know ain't's not really a word, but when we differentiate agnostic to antagonist, we can take the first portion of each word and use that as a mnemonic to differentiate. What is it doing? Is it making neurotransmitters go, agonist, or ain't go, antagonist? The big chunk here, we have some portion to the right about brain stimulation, but this last big chunk under drug therapy is to talk about 4 categorizations of drugs and their underlying uses. Antipsychotic drugs treat schizophrenia, as you would anticipate. The term psychotic was the name of the category above the boxes on schizophrenia. It's highly unlikely that you would actually need to know a pharmaceutical drug name on the AP exam. I will identify 2 by name, not on this box, but on a later box, that you might need to know because they have asked about it, not recently, but they have in the history of the College Board and the AP exam asked about a couple. Thorazine's not really one of them, but if you've watched certain movies or TV shows and individuals in that show have schizophrenia, it's not impossible to actually hear the name of that drug. I know I've watched shows and sort of recognize that name, so I will point out an actual brand name of a drug that you could be prescribed when treating schizophrenia. But what Thorazine and all antipsychotic drugs do is they work as antagonists to dopamine. Antagonist is a word we just talked about. It was on the right side of the previous box. It's a type of drug that reduces the effects of a neurotransmitter. In this case, it reduces the effects of dopamine. We talked all about how the leading theory behind the symptoms of schizophrenia is overactivity of dopamine. So if we isolate dopamine and reduce the activity, we might see a reduction in symptoms, which we actually typically do. Now, unfortunately, there is a possibility of taking too much of an antipsychotic drug. There's a unique side effect that is specific to antipsychotic drugs called tardive dyskinesia, in which the patient exhibits involuntary movements, often what might look like twitching or grimacing. This side effect can be avoided assuming that we dose appropriately, but there does seem to be a linkage between dopamine and movement. It's not a primary function back when we first talked about dopamine. It's more of what I'd classify as a secondary function, but there are some neural pathways where it's clear that movement and dopamine have some type of a connection. And if we reduce the effects of dopamine so much, there is some type of movement abnormalities that can be caused. Don't forget, one of the rare symptoms of schizophrenia was actually catatonia or catatonic movement, which we defined as movement abnormalities. So though it's not a primary function, it's highly unlikely that you would need to know in any great depth the connection between movement and dopamine, because honestly, we're still learning it now. You should know that that is at least a secondary function of dopamine, and there is some type of connection here between antipsychotic drugs and dopamine activity. But the primary neurotransmitter for movement is still acetylcholine. So do not disconnect that relationship back from earlier this year. This movement with dopamine is merely a secondary element. And of course, our primary function of dopamine is the reward pleasure system. The next category of drugs is anti-anxiety drugs. It's unlikely that the names Xanax or Ativan would appear on the AP exam, but culturally you may have heard of those drugs, so I will classify them appropriately so you are wary which of the 4 categories they fall into. Anti-anxiety drugs do what they sound like. They treat anxiety disorders. Things like generalized anxiety or social anxiety disorder, or maybe an individual who has a fear of flying or a diagnosable phobia, or even some of the related disorders that are not necessarily anxiety, but ones that we talked about within that essential task, like PTSD and OCD. What they do is they are agnostic drugs for GABA. GABA was the neurotransmitter that made you want to GABA a pillow. It was a neurotransmitter that reduced overall brain activity. In other words, relaxed the nervous system. That's precisely what an anti-anxiety drug like Ativan or Xanax would do. It would ease neural activity. One of the things with something like generalized anxiety disorder is there is this belief that neural activity is too active, the brain is simply overprocessing, and if we can reduce neural activity, now that might relieve the nerves of the patient and hopefully reduce their anxiety levels. It's important to note that we absolutely don't want to take an anti-anxiety drug with something like alcohol. Now we're mixing 2 depressants or 2 drugs that reduce overall brain activity. We also don't want to go cross-category, so we don't want to take an anti-anxiety drug with a stimulant like cocaine or an amphetamine, because that's going to send our brain 2 very differing messages. So those same underlying principles, when we talked about psychoactive drugs, do also apply when we're talking about the drugs used for pharmaceutical purposes. The third category over are antidepressants. It is important to write down the AKA. The full term that you might often see on the College Board's material are selective serotonin reuptake inhibitors. It's a little bit of a mouthful, but it often has the abbreviation SSRI, so selective serotonin reuptake inhibitors. Antidepressants treat depression. I mean, that is by and large their primary purpose, to treat mood disorders like depression. Not bipolar disorder, but at least depression. We have seen over the years that antidepressants actually have value to treat some types of anxiety and also OCD and other disorders. So I like to point out the fact that although the name has depressant in it, we can sometimes see antidepressants used for more than just mood disorders, such as depression, though I will absolutely say certainly that is a primary treatment. The name Prozac is one that I would actually like you to put into long-term memory. I've even added that here. For whatever reason, they like to include Prozac in the context of questions, so we'll definitely note that. The way Prozac works is if you follow the name of selective serotonin reuptake inhibitors, it actually tells you. Selective serotonin reuptake inhibitors, or SSRIs, block the reuptake of serotonin. So if you remember looking here at a picture of a synapse, which again is the space between two neurons, we have here at the top the presynaptic neuron, which means the end of the first neuron. Using our mnemonic back from that unit on biology, using the DAT or Datway mnemonic, this is the end of the first neuron. Next, we have the beginning of the next neuron. The synapse is the space between the two, and it is here in the synapse that neurotransmitters like serotonin have their effects. Drugs like Prozac essentially create a wall around the presynaptic cell, the presynaptic neuron, making it so that serotonin is locked in the synapse longer than normal. What that ultimately does is it magnifies and amplifies the effects of that neurotransmitter. Serotonin, as we talked about back in the unit on biology, has the primary function of mood regulation, which means in theory, if we can boost serotonin activity, we can boost the overall mood of the patient. And if we're treating something like a mood disorder such as depression, that can absolutely reduce depression symptoms. The last of the drugs that we need to know for drug therapy are mood stabilizers. The only disorder that we're really going to apply this to is bipolar disorder. This is an important thing to note. One of the risks with misdiagnosing bipolar disorder, and assuming that it's just depression, is that when an individual with bipolar disorder goes from mania to depression, or rather depression to mania, there is a dramatic shift, obviously, in behavior, right? Mania is the highest of highs, depression is the lowest of lows. If you were to seek medical attention in an episode of depression and be diagnosed with depression, you would likely be prescribed an antidepressant. And while depressed, that would actually be pretty effective. The problem is, if you take Prozac or any other type of antidepressant, when you alternate into mania, it's only going to amplify the highest of highs, which is obviously very dangerous. As a result, when we work with bipolar disorder, we actually try to prescribe mood stabilizers. The common mood stabilizer that is often prescribed is called lithium carbonate. And we actually don't really know how it works. We just know that it works pretty well treating bipolar disorder. So maybe in 10 years, I'll update this slide, go into more depth, kind of like how I went into the SSRI depth. But as of right now, I don't really have a definitive explanation for how it works. I will give you a little bit of a mnemonic, though. Carbon itself can sometimes be cold. The word polar and bipolar, obviously polar can be cold. Thinking about the North Pole, for example, you can make that connection between carbon and polar, make the connection between lithium carbonate and bipolar disorder. So those are the drugs. I will note that lithium carbonate is the other drug that you might get asked in a more direct manner, meaning out of, let's say, the last 15 years, the only drugs that I've seen them directly ask about by name are Prozac, which we emphasized in the last box, and then lithium carbonate. So be wary of those two. I reserve the right to ask you about those two. I will not ask you a question where Thorazine is the answer, or Xanax, or Ativan, or anything else. The last part of this unit is to talk about two other forms of therapy, one falling under the category of brain stimulation, and the final one a form of light therapy. ECT, or electroconvulsive therapy, is a treatment method that is designed to specifically treat severe forms of depression, specifically severe forms of depression in which the patient has not responded well to treatment. So, for example, if a patient has not responded to an SSRI, an antidepressant, a patient has tried forms of psychotherapy, meaning they've seen a cognitive therapist and it hasn't worked. They've seen a psychoanalyst utilizing free association and that Freud theory hasn't worked. They've tried the other insight therapy of the client-centered approach with the active listening and that non-judgmental, unconditional positive regard, hasn't worked. But we obviously still want to treat this depression. Therefore, we can try this, what some people call a treatment of last resort, where we essentially trigger what would almost be the equivalent of an intentional seizure in the patient. This might sound a little weird, but it's almost like unplugging the brain and plugging it back in and seeing if that fixes anything. We're going to intentionally send electrical currents into the brain, essentially cause this controlled seizure. Once the patient wakes up, some patients, certainly not all of them, but some patients report that this really significant and severe treatment can sometimes be an effective way of alleviating depression. I will say that there is a belief that for some, there is a bit of a placebo going on here, where a patient is asked, how are you feeling? Are you feeling more or less depressed now that you've undergone ECT or electroconvulsive therapy? And some might assume that, well, if I did such a significant form of treatment, of course I feel better. It is literally the treatment of last resort. This is the end of the line. So yes, of course I feel better. Because we don't exactly know why this works. There are some theories, but the placebo effect is definitely one of those in question. But any question that I've seen about this typically asks, why would you use ECT? And the specific disorder in which ECT is used is severe forms of depression. So we're talking about persistent depression that's lasted for years, or maybe even episodes of major depression that simply have not subsided. Do watch the clip here. It's interesting to see. It's a simulated, that's not a real actual individual undergoing ECT, but I absolutely think it's worth watching. The last one to talk about is the final form of treatment under the biological treatment category, under this biomedical approach. And it is what we call light exposure therapy. Light therapy or light exposure therapy is a way of treating seasonal affective disorder. That was one of the disorders that we didn't really define in great depth. The cultural name that people typically use is seasonal depression. We did allude to this on the box about major depressive disorder, but that is the presence of depression symptoms, specifically during, for example, the winter and fall months when it's a little bit darker outside and it sometimes can mess up your circadian rhythms. The light exposure box, as you can kind of see here, essentially mimics outdoor light, just simply indoors. It can sometimes trick your brain, sometimes reset your circadian rhythms a little bit, give you that artificial lighting that might alleviate the seasonal depression or the seasonal affective disorder. Of course, I made a little typo here. This, of course, should have a T in it. This last word should say lights. But as we wrap up this essential task on the biomedical approaches to treatment, we need to conclude with the understanding that each of these treatment methods, from brain stimulation to drugs, assume that disorders are a byproduct of typically brain chemistry imbalances. And if we can fix that brain chemistry imbalance, we can, in some capacity, alleviate the symptoms.